Welcome to Cornea Care. Today's topic deals with our accuracy in clinical diagnosis of fungal keratitis. In India, it's very common. Most of us depend on our clinical acumen as majority do not have access to lab facilities. So let's see how we do it and what is the likelihood of accurate diagnosis. Usually, history of trauma with vegetative matter and certain clinical features are considered predictors of fungal keratitis. This understanding is the result of efforts put by many ophthalmologists. In 1965, Kaufman and Wood published a paper where they listed following features as predictors of fungal keratitis. These clinical signs were Hyphate margins, which we also call serrated or feathery margins. These are the infiltrates with margins that are ill-defined, have multiple thin branch-like extensions into adjacent stroma. Firm elevated lesions, also called plaques, are common in fungal keratitis. These can be sometimes pigmented as seen in dematiaceous fungus. Endothelial exudates are small or large chunks of inflammatory exudates. Immune ring is the arrangement of infiltrate in arc-like pattern away from main infiltrate. They don't contain the causative organism, rather the antigens diffusing from the main infiltrate reacts with antibodies. That's why they are away from main infiltrate and they heal without leaving any scar. But Kaufman's observation was based on 15 patients only. So people digged in a bit deeper into these features to know their reliability. 40 years after Kaufman's paper, a group studied ulcer patients in South India and Ghana and attempted to determine to what extent the presence of certain clinical features may be used to provide a rapid, presumptive diagnosis of fungal keratitis. They studied the presence of clinical features among fungal and bacterial cases. 5 clinical features: serrated margins, raised lesions, pigmentation, dry surface, and satellite lesions were found to have significant fungal association. On further statistical analysis, probability of fungal infection was 63% if any of these 3 features were present, but increased to 83% if all 3 were present. So hyphate margins, plaques, and pigmentation turned out to be the most important clinical features. A recent study from Nepal also had noted that 4 features had significant fungal association. Trauma with organic matter was also included. Each had 30% chances of being fungal, and if all 4 were present, then the chances increased to 96%. In a photo survey, 66% fungal cases could be differentiated from bacterial based on photograph only. Among clinical signs, feathery margins had a strong prediction. In this survey, all participants were cornea consultants or cornea fellows, but in reality, majority of ulcers are seen by general practitioner. Can we make a mistake in picking up feathery margins? Why not? To err is human. Sometimes these hyphate edges are mistaken as dendrite. This young male was referred to us by our colleague ophthalmologist for corneal scrapings as he suspected fungal keratitis. Typical dry texture infiltrate with feathery margins is even clinical suggestive of fungal keratitis. But the same ophthalmologist diagnosed it as dendrogeographic ulcer 3 days ago. Feathery extensions of infiltrate were confused as dendrite and acivir ointment started. Good thing is that he reviewed within 3 days and correct diagnosis was made. We started antifungal drops and he responded to medication. In other case, this dense central infiltrate without any feathery margins or typical fungal features was positive on KOH. Here too, the hyphate margins were mistaken as dendrites just 4 days ago. To avoid this mistake, always remember that dendrite is a type of epithelial defect, whereas feathery margins are stromal extensions. Staining is very helpful. We have discussed it in earlier video too. Another problem is that feathery margins may not remain throughout the course. In this case, within 5 days, ulcer had lost the typical fungal look. It's a common misconception that fungal lesions progress slow. They can progress very fast. To further complicate the matter, we have a study where risk factors and clinical features of fungal, bacterial, and acanthamoeba were compared to know how we can differentiate between them. And they concluded that fungal and bacterial cannot be differentiated. One reason for this conclusion may be that in tertiary centers, patients reach very late and advanced ulcers lose feathery margins. I have also noticed same thing in my cornea practice. Clinical features can be very confusing many times, as we can see in numerous examples. So if we want to improve our diagnosis, we must do KOH, a very simple and easy test as we have already covered in previous video. So to conclude, our accuracy in diagnosing fungal keratitis varies. It's around 66%, and that too if we pay close attention to history and clinical features and patient has come early. In pigmented plaques, we are lucky because they are almost diagnostic of fungal. But we can't be lucky always, and clinical dilemmas are very common. So we should incorporate KOH in our practice. In the absence, pay very close attention to the features during follow-up so that we can recognize our mistakes early. Thanks for watching.